So what we're going to do is I have a bunch of questions that I heard listening. I hope y'all have some questions, and so we'll go back and forth. But, you know, I really want to start off because we never really defined it. And Chrissie touched on this. Like, what is a disaster? Now, I don't want to minimize any loss of life, right? But when you look at so in the Bahamas, amazing destruction, 27, getting into that kind of death toll. Diabetes kills more in a day. Heart disease kills more in a day. What do we consider a disaster, a crisis, and how does a hurricane differ from opioids? So I throw that out to you guys. Now you respond. So I'll throw out a theory. I'm going to throw out a theory. I think disaster needs to be defined by control. Okay? So at the end of the day, I think opioids, our inability to confront the opioid crisis is a lack of political will, not a lack of preparedness. Our inability to confront diabetes is a lack of political will. It is not a lack of political will because a hurricane decides to form, because a bomber decides to take an unholy action. It is not within our control. So I'm throwing that out, but I want to hear what y'all think.
So I think that, can you hear me? Okay. So it just goes back to historical. You have to go back in history, when the initial, even Red Cross was formed and all of that semantics. So disasters is usually defined by a specific event, happening in our lives that disrupts our lives, right? It's about being disruptive. Not to say that diabetes and opioid is not a disaster in itself, in terms of lives lost, but I don't think it's seen that way. I think it's a moment in time. It's a moment in time which is defined by either it's man-made or it's made by nature, right? So those are the definitions, the semantics behind what's a disaster. And historically, you could go back, to the wars and everything, and it's about definition. So
you wouldn't put opioid in that definition?
Opioid is a moment in time, right, which we have seen an increased use of opioids happening to us, and it was man-made, right? So it was man-made. So,
when does something like obesity transition? So it kind of, like obesity went up, and was it a crisis, and then just because we stayed heavy for a while, it became not a crisis?
Well, I know.
That's provocative. That's my job.
Yes, very yes. But people will not define. You will find the majority of the population will not define the opioid as a disaster. They will describe it as a crisis. The crisis, right? A crisis. They will not define diabetes as a disaster. They won't. Because disaster in their minds is a specific event that happens in our lives that is either man-made, right, or made by nature. That's the bottom line. That's mine.
I can't hear myself, so can I? Yeah. The question you ask, I think, is an interesting one and has, I'm sure, nuanced answers, and I'm not going to give one of those. What I'm going to do is I'm going to talk about the disaster and kind of the legal implications of calling something a disaster. So in my role and in many people's role, we sometimes have to declare a disaster, a public health disaster, or elected officials usually declare disasters. And that brings with it a few tools that we don't otherwise have. And so on a more technical level, a disaster is something that we can name, and if it meets certain criteria, and that allows us relief from certain regulation. It allows us to bring in resources, to pay for the resources that we bring in. So that's one difference. I think we all are collectively, I'll use the word blame, but it's not the way I intend it, to blame for the blurring of the use of disaster, because we use the infrastructure like ICS for lots of different events now. And I think that's a good thing, which why blame was not the right word, because a lot of our preparedness and exercising of ICS happens in less urgent time frames. And so when you have an urgent time frame, you have some familiarity with it. So.
You know, another argument that I wanted to add to this is we as public health officers are always, by community groups, wanting to define something in your community as a public health issue, right? Take gun violence, right? That's another issue. How many people came when I was a health officer to tell me, Lillian, you have to declare our gun problem in our community as a public health issue. And that happens to all health officers. Or declare the opioid crisis as a public health issue, via policy or via statement or via public communication. So that's another, so what is a disaster? What is a public health issue? There's great similarities between both things.
Yes, if your question, what is the real disaster? The real disaster with us in migrant situation is the organization. In the beginning, with the Caravana Migrante, we don't have a plan. And if we don't have a plan, all the people have a disaster in all the city. And the city have a bad response to the people, to the migrant people. Then, in our experience, the real disaster is don't have a plan for the response to different situations in our state.
I mean, I think you're asking a really good question, not just provocative, but I think the realities that we face in the communities that we all lead and work in, and we have this power. You pointed out, declaring a public health beyond just an issue, but a public health emergency. And why haven't we done that locally in our communities, in our cities? And that's because of political will, the context, and resources. And so if we did declare, we do have these discussions, and it's not philosophical, they're practical realities in terms of, well, what does that mean in terms of resources? If we're in charge, what does, using opioids or gun violence as an example, is it me, Monica, at the local health department, what do I know about firearms, right? And so I think it's a complicated question, and I think you hit the nail on the head in terms of political will. When you look at HIV and ending the epidemic, I mean, we can rattle off many different examples, and I think what happens is when the public is inundated by, this is a crisis or this is an emergency, it becomes routine, as Chrissie was pointing out.
So when we talked about some power and some funding. So I grew up outside of Boston, and so the bombing, was a particular interest to me. And so, of course, I turn on CNN, and what do we see? We see people in uniforms. We see police. We see fire. I think one of our biggest weaknesses in public health is we need a uniform, because then people might know who we actually are. So Barbara Ferrer once commented to me, who was Monica's predecessor in Boston, that the reason the Boston bombing, the response was so effective is because public health was the backbone there. That public health brought these groups together. Public health made it so that when this happened, those 4-minute response times were really the seeds of public health. But no one ever said the word. No one ever gave us credit. So when the funding starts to drop and we say, gee, we're really needed, people don't recognize what role we actually played because no one even knew we were there. So how important is it? Because what we heard here were disaster stories, but we heard leadership stories, right? And I think that's what's really we should take away from this is these are amazing leaders who are telling us about their leadership experiences. As a leader in a health department, how important is it that we're out in front and that people recognize that we were leading these charges? And I understand our need for humility, but let me be blunt, humility does not play well in Congress. So, sorry, did you all not know that? So, what are your thoughts? Especially, I'll start with you, Monica, because you're there, you're in Boston, and you know that the funding struggles. How do you lead while still being humble, but still fighting for funding? So, what do you think?
It's tough, because that's not what we as public health professionals, I'll speak for me, that we don't necessarily, public health is always silent in the background, working day in and day out. You wouldn't normally hear about the health department, but for the fact that we played a lead role in the bombing response activities. I was actually not in Boston. I was already working in Virginia near you and Chrissie when that all happened. And another framework that I would throw out there is we think about the future of public health and governmental public health in particular is the Public Health 3.0 Chief Health Strategist model. So I don't know how many of you are familiar with that Chief Health Strategist and all the key elements.
If you're not, you've got to Google it.
Google it.
Google Chief Health Strategist and Google Public Health 3.0. You got to know these frameworks. They're really important.
And especially since we're in a school of public health, as Chrissie reminded us, when we think about sort of those core public health capabilities and the future role is really, I feel like it's just putting a label and a framework around what we do, but then kicking it up a notch. So we should not only see ourselves as providing informatics and surveillance and the outreach and the education and the policy and advocacy, but as really leading as the chief health strategist. And so bridging all the different multi-jurisdictional agencies that are involved in any kind of response is how we need to lead in public health, to be more prominent and be more visible, just beyond the core public health. So I would ask that you go back and Google it, as Brian said, so colleagues from CDC and CMMI, former administration officials really framed the Public Health 3.0 framework, and that's how many of us are looking at our new role.
I will pass this on because I don't lead a public health department.
Yeah,
but I'm going to say something. I think we know each other really well. Now I've lost my train of thought. I think there are different places to play different roles, right? So I think what I have learned from a coalition of leaders is everybody has a different style and everybody knows their community. So in some communities, it is absolutely going to be the health commissioner or whatever his or her title is out front, like saying what needs to be said. And in other communities, it might be the mayor or it might be the police chief or whatever, but it needs to work in the local community. But then where the work that I do comes into play is I need to be able to tell those stories to members of Congress, to the CDC, to people making funding and policy decisions at a 10,000-foot level. And that's where I think across the board, governmental public health in particular needs to be less humble. We need to be able to say, here's what we did, here's why we couldn't do it, and here's what we need. So that's, I think there's two different levels to the discussion.
Right, so I'm going to, I have two other really fun questions, but audience, any questions for anybody out there? Yes, sir.
County and city, like, what is their role in rehousing?
Well, let me take that. So displacement, depending on the type of event, definitely in the event of Boston Strong, the Boston bombing, there was displacement there. So, Monica could talk about that. In terms of Miami, the major displacement that we have seen is hurricanes, right? So definitely one of the greatest programs that we established almost 12 years ago after Andrew was called the Medical Management Program. It's a contract with all of the healthcare systems that they will, for free, house those patients that are electrical dependent, because we did not want any patient that depended on oxygen or electricity to live, to be in any shelter. So that program has sustained itself over 12 years, and thank God we have not lost a life in any of our regular shelters, either it be general population or our what we call special needs shelters due to lack of oxygen. So they're all immediately, they sign up for the program and they're sent to the local hospitals. Knowing where the storm is coming, we try to send them to the hospitals that are not going to be impacted by the storm. And we could do this type of program because we have a good amount of hospitals in our region that we could do that. The good thing about Florida is that we have a statewide system. So we could send patients, for example, of skilled nursing facilities and so forth to places where the storm is not coming. So we have multiple different strategies to be able to house our folks. Definitely the population that we always struggle with is the elderly who live alone, who don't have any type of resources and do not have family that take care of them, have no one basically taking care of them. And we have a lot of them in Miami that live by themselves. And we find out about them at the last moment that they come to the shelter without any type of plan or management plan. But that is a big issue. And the big issue is trying to get the people back to their homes, right? That is the big issue, because if there's no electricity, if there is no food or no access to food at that time, you can't send them back. So you have to keep them in the shelter. And keeping people in the shelter after 3 days is a nightmare, folks. It's not easy. I feel for the Savannah people in Georgia. They've been now in that shelter going on 4 days, and still the storm. It's approaching now, today or tomorrow. So that's a really, really tough situation. So I'm going to stop there.
So, yeah, we sheltered people for a little over 3 months as a public health department, in concert with our ESF6 people. And so one of the frustrating things from the medical standpoint is, in a disaster, the housing and the sheltering is actually a different organization. They're more of an independent variable, like where there's going to be shelters. And then we, as medical, are the dependent variable, kind of just responding to that. And that can be very difficult because their motivations may be different than ours. And so staffing 13 shelters is a lot harder than staffing 4 with medical folks. So just on the short run, where people are housed, medical, in my experience, doesn't have much influence. I think this is one of those places where you say, how much of what public health does on a daily basis and how they can be working in the community in the housing first models and making sure that there's affordable housing. So in the town of Chico, they had an influx of 15 years of worth of growth in one day. They had a 1% vacancy rental rate before the fire. And so what happened is property values went up 24%. People who owned rentals kicked their low-income rentees out, sold those properties, and it filters all the way down and it becomes an enormous housing crisis that we're still having. And I'm not sure that really you can anticipate and prepare for all of those things, but any work that you've done as core public health to be thinking about housing first, housing options, affordable housing, prepares you to respond to that much better than if you haven't done that work.
Though we have, from a policy standpoint, right, that's where we need to be active on the policy front, because a disaster should not be an opportunity for predatory capitalism, right? A disaster it shouldn't be. I know it often is. How do we then put in place things that say, you can't, we amp up some of the eviction restrictions. We make sure that, rents can't rise more than 5% in the next 6 months. This was, this is the issue. We talk about homelessness as a crisis now. Ultimately, when you look at Seattle, you had a lot of folks who were doing what even the most conservative politician would tell you we should do. I went to school, I have my kids, I'm renting a place, my kids go to school, I'm married, I am the perfect American family, and I'm doing great in Seattle. And then my lease runs out, and I expect that I'm going to renew my lease, but it gets jacked up by a factor of 7. And now I'm housing unstable. And now I'm staying at the hotel at a couple nights a week. And then my kids aren't now going to school as much, and now I lose my job. And at the end of the day, they look at me and they say what I have done, right, to make my health not where it needs to be. But it's not a failure of the individual, it's a failure of the system. Because we needed one policy that just said, on an existing lease, you cannot raise the rent more than 5%. On a new lease, do what you want. It's the balance between compassionate capitalism and predatory capitalism. Unfortunately, those are now at imbalance. And that's where I think we're seeing a lot of the drive of social issues, social determinants, driving our ill health. So, that's like we need to, as leaders in public health, that policy response needs to be there.
The good thing, Brian, that's happening after all of these events, and remember, all of these events are individual events that we learn from, right? We learn from them. And good policymakers, good lawmakers go back to their next session in either at the state, congressional level, and they make laws to address these issues. They address gouging issues. They address the housing issues, hopefully, right? In California, things will be addressed. In Florida, after the 204, that we had 4 hurricanes crisscross the state, one after another one, great laws were developed to be able to protect the elderly, to be able to protect public health, to be able to. So there's always a good law that could be done. Legislation is possible to address during that. So being an advocate for that type of legislation is extremely important. After this measles outbreak that we're having in New York that you mentioned, Chrissie, I see good work because California has done tremendous work with vaccination, and I congratulate them with that. But I think good laws will be coming as a result of this measles outbreak, too, in the different parts of the state, especially New York State.
Well, New York State passed a law also about exemptions. I think the one thing I just wanted to say about Seattle, because we talked about this in this presentation I referenced, is they've figured out that they can't even build their way out of this homelessness crisis. So they literally have all these people that, if they had all the money in the world, they couldn't just find them a house. So, we failed on the policy piece, and the intervention is the systems level now. Where are we going to put them? And then we need to think about, the policy moving forward. Gina has a question up there.
Audience questions?
So just quickly building on this last comment, I mean, in many ways, I think many of these so-called disasters can be thought of as failures of policy, really. So they're really sort of the manifestation of a failure of a policy, gun, measles, even fires and floods, environmental policy. So well, if we start framing these things not just as a disaster, something just happened out of the blue, but something that is really a failure of prevention, and prevention in the public health sense is policy, then, how can we communicate about these things in a different way to really leverage them to motivate the kind of policy change that we need to prevent these things from happening in the first place?
Absolutely. In the back, a question?
Actually, I just wanted to say it's about time for our break.
No, we have 5. No. The young lady in front said 5 minutes. So she held up the thing that said 5 minutes. So I'm going to.
I have 10:35.
Yep. Okay, so another question. Okay. There you go, Jim.
One aspect of emergency public health practice is the practice of doing after-action assessments, and I'd be curious if you could comment on your experience with after-action assessments and what you've learned about how to do those well. What makes a good after-action assessment?
I'd like to comment on that because that's something that we in Miami have, with our healthcare coalitions and all of our partners, are a stickler at. This whole quality improvement process, that's the way we see it. It's an after-action report, or we call them hot washes. We have to definitely include everybody that was involved, right? We do hot washes with different levels. It could be at the executive level, leadership level, community level, but we take our time to do those, write them down, do agreements, and make sure that we have an after-action plan, and we use a system that's called WebEOC, that everybody's connected, and those plans are living documents. They're not one-time hot wash, put all your sentiments down. They have continuity, and they have people following them up to make sure. And if it is a law that needs to be changed or a legislation, we have our governmental legislative people that follow up. Because don't do a hot wash just to do them if you're not going to follow up on them.
My favorite public health. Hot wash. No, I definitely agree with what Lillian said, and it's a great tool in terms of being objective when there have been mistakes made and putting it in writing and not placing blame on anyone. It is a great way for us. We use the hot washes at different levels as well for small events, large-scale events, and then you memorialize it, and you go back to your multi-agency partners and you refine, and like you said, it's continuous learning and improving upon each event.
So I was just going to add that sometimes the jurisdiction does a hot wash as a whole, and that can kind of be consumed completely by fire and law enforcement. And so what we found helpful is to participate that, but also to have a public health hot wash after action report that's separate from that so that we're not lost with the big boys.
So as time runs out, there is one thing I want you to take away, and it's a point that Chrissie made. Nobody on this panel, the Philadelphia Department of Health, most locals don't get money for this. Okay, so let's really, in your studies, because it's a school of public health, let's remember that money for public health in 90% of the situations is running through the state, right? It's more. So Harris County had Hurricane Harvey. That was a choice that the Department of State Health Services made. When they get the money in from the feds, they had, and I worked in Texas DSHS, so we, at some point, had to make a decision. How much money are we going to put here at the state to build capacity? How much money are we going to send to the local? And if we don't really think through the balance between where the funds are going, we are really in line for a much bigger disaster at some point, because we have to have the money to do the work. You all brought up the point, every one of these disasters was local, and I don't know about you, but I can't see Harrisburg from here, and they're the ones making decisions on Philadelphia public health when it comes to disaster preparedness. So thanks, everybody.
Thank you.